Assalamualaikum and good day to everyone. Today, I'll be presenting on a topic about monitoring the coagulation status of major trauma patient with viscoelastic devices. Let me start with the introduction. Major hemorrhage following trauma is responsible for nearly half of the annual 4.6 million injury deaths that occurs worldwide. Most of them die either early from exsanguination or later from multiple organ dysfunction or associated TBI. You can see in this graph, it shows that the leading cause of preventable death following trauma is due to hemorrhage. So why do they bleed to death? This is largely attributed to the exacerbation of bleeding by dysfunctional hemostasis that occurs following severe injury. In about quarter of patients with severe injury, acute traumatic coagulopathy or ATC sets in within half an hour post-injury, and this is associated with high rate of mortality. Therefore, early detection and correction of coagulopathy is paramount in order to improve the outcome of these patients. Current trauma resuscitation approach focuses on early hemorrhage control and management of trauma-induced coagulopathy or TIC with timely administration of balanced transfusion. As I mentioned in my earlier slide, shortly after a major insult to the body, acute traumatic coagulopathy will set in within minutes. This is unpreventable. Once we start to resuscitate the patient, we tend to introduce something called resuscitation-induced coagulopathy due to injudicious fluid and blood product administration, as well as not addressing the lethal diamond of trauma adequately. Several hours after the injury, the patient will shift into a prothrombotic phase. This spectrum of hemostatic dysfunction is known as trauma-induced coagulopathy. This cannot be totally prevented. However, we can mitigate this by instituting a balanced transfusion strategy. So, what is a balanced transfusion strategy? It is a strategy whereby during the initial phase of resuscitation of a bleeding patient, we institute blood and blood products in a fixed ratio manner of 1:1:1 ratio. This should only happen from the point of arrival of patient until the availability of coagulation parameters. Once we have our coagulation parameters, we should use those results to change our strategy to goal-directed transfusion. This diagram will give you a better idea on how to institute a balanced transfusion strategy in a bleeding patient. During the initial phase, administer blood in a fixed ratio of 1:1:1. Once you obtain your coagulation parameters, change to a goal-directed transfusion as soon as possible. This is a massive hemorrhage protocol used in one of the leading trauma centers in the UK. They also highlighted the importance of using coagulation parameters to guide transfusion as soon as it becomes available. So how do we put goal-directed transfusion into practice? There are two ways to do this. The first way is by utilizing viscoelastic hemostatic assays, and the second way is by utilizing conventional coagulation tests. Among these two, which one is better? I will try to answer this question as we go through my presentation. I'll start by explaining about conventional coagulation tests. How does it help to assess hemostasis and guide transfusion, and actually, what are they? They are the PT-INR, fibrinogen level, and also platelet count. INR value of more than 1.2 has been generally used to define trauma-induced coagulopathy. So when the level is more than 1.2, patient should be given fresh frozen plasma. If the fibrinogen level is less than 2 grams per liter, patient would require cryoprecipitate administration. And when the platelet count is found to be less than 100, we should give the patient platelet concentrates. CCT has many disadvantages. One of the main disadvantages is its slow turnaround time. It takes about almost an hour to get the results back. Furthermore, the blood samples have to be sent to the lab to be tested. Even though it tests various parts of coagulation cascade, but it does it in isolation, means that 3 different tests must be carried out in order to get those results. Furthermore, it is not reliably associated with coagulopathy. Actually, CCT was not designed to evaluate TIC. Other than that, PT-INR only measure the plasma-dependent enzymatic component of clotting. In other words, it only measures a portion of secondary hemostasis. Finally, it do not account for the contribution of the endothelium and platelet function. An alternative to CCT is by utilizing viscoelastic hemostatic assays or VHA to guide transfusion. What is VHA? It is a point-of-care device, which means this device can be placed in ED. It was developed to provide depiction of an individual's coagulation profile. It provides information regarding lifespan of a clot or global hemostasis in just one single test. It tells us how fast does the clot start to form, during which clotting factors and fibrinogen are responsible, what's the maximal clot strength, which indicates platelet function, and also it tells us how fast does the clot breaks down, or whether or not there is presence of hyperfibrinolysis. It produces first result which can be used to guide transfusion in just 5 to 10 minutes. VHA devices are mainly used in 3 main settings, which are cardiac surgery, liver transplantation, and of course, in a bleeding trauma patient. However, bear in mind that we should always use this device along with clinical situation or picture to guide our patient management. There are 3 types of VHA. The first type is known as thromboelastometry or ROTEM. The second type is known as thromboelastography or TEG, and the third type is known as sonoclot. Sonoclot is mainly used for research purposes. How it works? Both TEG and ROTEM use similar principle based on a cup and pin method to measure the mechanical properties of clot formation in whole blood. First, the blood sample has to be placed into this cup. When the device is started, either the cup or the pin will start to rotate back and forth. As the blood starts to form clot or fibrin, there will be resistance to the movement of the pin or the cup. Or in other words, there will be impedance. This impedance will be translated into tracing, which look like this. Both TEG and VHA tracings look identical. Only the parameters used to describe each phase are a bit different. Typically, the phases are divided into 4, which are clot formation time, which is identified as R or CT, clot kinetics, which is identified as K or alpha angle, clot strength, identified as MA or MCF, and clot lysis, which is identified as LY or CL. VHA doesn't only produce result in the form of tracing, it also produces result in the form of alphabet and also numbers, as you can see in this diagram. This is me operating a ROTEM device to guide blood transfusion when I was doing my fellowship in the UK. However, this is an older version of the device in which you have to pipette the blood into the cup. The latest version of the device is much more easier to be used, as it uses cartridge method and eliminates the need for pipetting. This is how a ROTEM result looks like on a monitor, and the results can also be printed out on a piece of paper. How to diagnose coagulopathy with VHA? VHA can detect 3 types of clotting abnormalities. It can tell us whether there are any prolongation of clot formation, any reduction in clot strength, or any increase in the rate of fibrinolysis. To determine whether the values generated by the device are abnormal or no, the results should be compared with the readily available algorithms to guide transfusion. There are many transfusion algorithms that are available, mostly derived from expert opinion. The only data-driven algorithm was taken from the Hemostatic study, which I will mention later on. This is an example of VHA transfusion algorithm. This was taken from the Hemostatic study. Believe me, it's not as complicated as it looks like. For example, let's say we take the ROTEM results here. If these values are more than the numbers mentioned, means that there's problem with clot initiation or clot formation. This patient should be given 4 units of FFP. Next, if the 5th CA5 is less than 10 mm, means that there's problem with clot kinetics. This patient should be given fibrinogen concentrate or cryoprecipitate. If these values are less than 30, there is a problem for the clot to achieve adequate strength. Indicates problem with platelets. This patient should be given or transfused with platelets. If Li30 is less than 85, means that there is presence of hyperfibrinolysis and patient should receive 1 gram of tranexamic acid. This is another VHA algorithm that is used in a leading trauma center in the UK. I just want to highlight that it is mentioned here that ROTEM is repeatable 15 minutes after blood products in order to assess treatment response and to further guide therapy. This means a single value is inadequate. A serial measurement must be carried out in order to optimize resuscitation and to guide our transfusion therapy. This is how different types of VHA tracings looks like and its interpretation. The first tracing is how a normal VHA tracing looks like. The rest are all the abnormal tracing that you can get when there is presence of coagulopathy. Let's say we take this second abnormal tracing as an example. It shows that there is reduction in the angle of the tracing. This means there is problem with the fibrinogen and this patient would require administration of cryoprecipitate. There are plenty of evidence which supports the use of VHA to detect coagulopathy and guide transfusion of blood component in a bleeding patient. However, robust multi-center and international RCT which looks into the effectiveness of VHA-guided therapy is lacking, particularly in trauma. Many of the studies supporting the use of VHA in trauma are actually just observational studies and not ideally designed to answer this question. This is one of the 2 RCT that was carried out in order to look into the effectiveness of VHA in trauma. In this study, MTP goal-directed by VHA was compared with MTP goal-directed with CCT. This was done in an academic level 1 trauma center in the US. Primary outcome was 28 days survival and it involved 111 patients. The results showed significant improvement in terms of survival in the VHA group when compared with the CCT group, and the CCT group was found to require more plasma and platelet units during the first 2 hours. The Kaplan-Meier curve shows significant benefit in terms of survival in the VHA group. This is another large-scale RCT which was carried out across Europe recently. The result of this study was eagerly awaited by many across the world. Comparisons were made between MTP guided by VHA and guided by CCT. Primary outcome was survival and free of massive transfusion at 24 hours. Surprisingly, the results showed no difference in overall outcomes between the VHA and CCT group. Only in a pre-specified subgroup of 74 patients with TBI, the results favored the VHA group. Even though results of the Hemostatic study were not statistically significant, some benefit were actually seen in the VHA group, as you can view in this graph. Observational studies showed that VHA-guided transfusion algorithm reduced mortality, reduced allogenic transfusion, and changed transfusion practices. VHA was also found to have utility in prognostication. Any abnormal values were associated with increased mortality and morbidity in trauma patients. Meta-analysis, which was not specific to trauma, demonstrated that VHA decreased transfusion of unnecessary blood products and reduced morbidity in bleeding patients. It was also found to be cost-saving when compared with CCT. European Guideline on Management of Major Bleeding and British Society for Hematology Guideline released a recommendation of Grade 1C and Grade 2B for the usage of VHA in a bleeding trauma patient. The following are the advantages of VHA. Firstly, it reduced turnaround time from blood sampling to detection of coagulopathy. This is because it is a POC device which can be placed and run in ED itself. Secondly, it enables clinicians to integrate results with clinical judgment while resuscitating. It provides functional and dynamic analysis of global hemostasis with a just single test. It also has potential reduction in mortality and morbidity, blood product consumption, and also operational costs. Last but not least, the results are viewable in real time, even from remote viewing platforms such as mobile phone. This is important in a bleeding trauma patient who are usually transported from one place to another during the initial phase of resuscitation. General practice points for managing major hemorrhage using VHA. What you can do is initially transfuse an exsanguinating patient empirically with SAFE-O, MTP pack, and administer TXA, and shift to a goal-directed transfusion with VHA guidance as soon as possible. This is known as hybrid resuscitation, or initially transfuse SAFE-O and administer TXA and determine the need for other blood components with VHA. I would name this rapid transfusion protocol. A single measurement is inadequate. VHA need to be done serially in order to look how the patient responds and to further guide therapy. Normal VHA parameters means bleeding due to coagulopathy is unlikely and patient might not need any transfusion of blood component. Ladies and gentlemen, currently we are in the era of precision medicine, whereby sophisticated protocols and technology develop to precisely guide our treatment. However, these novel therapies must be evaluated through RCT even though they intuitively appear superior. In conclusion, VHA have clear advantages as POC device for monitoring major hemorrhage, although strong evidence supporting its usage is still lacking. In our local setting, it takes a long time to get our CCT results back. Thus, to have VHA in ED would be a great advantage, especially in centers with high trauma patient load. This will definitely lead to improved quality of trauma care delivered to our patients, lead to possible reduction in mortality and also possible reduction in blood product usage. At the moment, we should at least incorporate CCT into our hemorrhage protocols to fine-tune our resuscitation. I believe more evidence will emerge soon to support the use of VHA in a bleeding trauma patient. This is because there are 11 ongoing clinical trials which are looking into this matter. With that, I end my presentation. Thank you. I would like to thank the organizer for providing me this opportunity to share my ideas and knowledge in this prestigious conference. Thank you again. Bye and take care.